So yes, Subodh kindly asked me to talk to you about our latest trial in heart failure, which was Finearts heart failure, in which we looked at the non-steroidal mineralocorticoid receptor antagonist, or MRA, Finerenone, and this was again a joint Glasgow-Boston collaboration with Bayer, who was the sponsor of this trial. So for those of you who don't know me, this is where I'm based. I'm in Scotland, near one of President Trump's golf courses, but hopefully that's all the real estate that he wants off us. Maybe not.
Well, he wants a lot more from us, as you know. So.
Maybe not so funny for you guys. These are my disclosures, and this is the background to Finearts. So, unlike heart failure with reduced ejection fraction, patients who've got heart failure and an ejection fraction above 40% really have few options. In fact, until recently, they had no evidence-based treatment. Of course, now we have the SGLT2 inhibitors, so we're constantly looking for additional therapies for that very needy group. We sort of got a hint that conventional steroidal MRAs, such as spironolactone, Finerenone, may help in these patients, but we had no definitive proof. That is because the one large trial that attempted to look at whether or not spironolactone was helpful in these patients, the TopCat trial, had some problems with its conduct and overall was a neutral trial. And you all, I'm sure, know the discussion and debate that's taken place since the results of TopCat were presented and published. So the advent of this new class of MRAs, they are chemically different, whether they're meaningfully different clinically, I'll come back to later, but this new class of MRAs gives us the opportunity to come back and look at this question again. The lead compound in this new class is Finerenone, and Finerenone had already been studied in two very large trials in patients with type 2 diabetes and chronic kidney disease and been shown to be effective in those patients. So we knew that we had a drug that works and one that was reasonably safe. So we designed this trial in patients with heart failure mildly reduced to preserved ejection fraction. These are the key inclusion and exclusion criteria. I don't think there's anything surprising or controversial here. The inclusion criteria really reflect very much what we've been doing for the past 20 years in trials in this type of heart failure. We were prepared to go down to an eGFR that might be a little lower than you would have expected, an eGFR of 25. We were willing to do that because, of course, we'd seen that Finerenone was, as I said, well tolerated in people with type 2 diabetes and chronic kidney disease. So we reckoned that we could go a little bit lower than we might have done with conventional MRAs in patients with heart failure. So this is the trial schema. Patients were randomized to placebo or Finerenone in a dose of up to 40 milligrams daily. Dosing was based on eGFR. And maybe the only important point to make here is that 40 milligrams had not been studied before in a large-scale trial. The two chronic kidney disease trials in patients with type 2 diabetes had used a maximum dose of 20 milligrams. So this was the first time that 40 milligrams had been used, and we went up to a dose of 40 milligrams in people who had an eGFR above 60. These are the endpoints that we pre-specified. The primary endpoint was a total events endpoint. So we looked at worsening heart failure events, both first events and repeat or recurrent events, plus cardiovascular deaths. Different than the usual time to first event endpoint. And then we looked at KCCQ, a patient-reported outcome, NYHA class change. We had a lot of discussion about this composite renal endpoint. This was very much the sponsor's choice. Scott Solomon and I, who co-led this trial, were not at all convinced that we could demonstrate a benefit in this. And then, of course, as always, we look at all-cause mortality, although we didn't include that as an alpha-controlled endpoint. So we published these results last year in the autumn, at the end of summer, and you can see here that Subodh and Shelley Zeroth were our two Canadian national leaders in this global trial. 37 countries participated. You can see we enrolled 116 patients in Canada out of the 6,001 patients in total. Here are those patients. Again, no real surprises. The average age was 72. That's quite a bit older than the average age in patients with heart failure and reduced ejection fraction trials, where they're typically around 64, 65 years of age, instead of just under a quarter of patients being women. Now we're seeing it's closer to half of patients being women. That's what we expect in patients with a higher ejection fraction. And then you can see that the mean BMI in these patients was quite high, 30. And you can see the usual comorbidities, particularly hypertension, a lot of diabetes, although relatively few patients with documented myocardial infarction, contrasting a lot with patients who've got heart failure and reduced ejection fraction. This is background treatment. Really continues to puzzle me, I think, a little bit, why we as physicians use beta blockers so widely in these patients, but we do. We've seen this over and over again in the trials that we've done. Obviously, very widespread use of renin-angiotensin system blockers, and everybody was on a diuretic per protocol. And we had some patients getting an SGLT2 inhibitor. When we started this trial, SGLT2 inhibitors had not been approved or recommended in guidelines for patients with this heart failure phenotype. So this is the primary endpoint. You can see that we saw a 16% statistically significant relative risk reduction. There was a reasonably large absolute rate reduction. And you can also see that the treatment effect developed very early. We could demonstrate this statistically. So the benefit of this treatment, as we saw with SGLT2 inhibitors, accrues pretty quickly. So here are the components of the primary endpoint, and this is where it gets interesting. So now you see total heart failure events, 18% relative risk reduction, clearly statistically significant, again, early onset of benefit. But you see over here on the right-hand side panel of this figure that there was no significant reduction in cardiovascular death, although cardiovascular death is relatively infrequent in these patients. And this is really something that I think we haven't totally got to grips with, and we're going to have to change what we do in the future if we want to see whether these treatments do reduce cardiovascular mortality. And I'll try and explain what I mean by that using this slide. So there are two panels in this slide that look at causes of death in patients with heart failure according to left ventricular ejection fraction. So the upper slide here shows you the mortality rate per 100 patient years of follow-up in about just under 25,000 patients in all the large randomized trials that we've done over the past couple of decades. You can see over here patients with a low ejection fraction of a very high annualized mortality rate. Patients with a normal ejection fraction have a much lower annualized mortality rate. So immediately, of course, that makes it more difficult to demonstrate a benefit on mortality. The panel at the bottom shows you the proportion of deaths in each of those ejection fraction buckets due to different causes. So at the top, the sort of pale brown color is sudden death, sudden cardiac death, presumed arrhythmic death. The purple color is death from heart failure. And then as you go down, you see other cardiovascular deaths, such as myocardial infarction, stroke, pulmonary embolism, aortic aneurysm, then deaths from unknown causes, and at the bottom, non-cardiovascular deaths, which are shown in blue, the pale blue color, and these are predominantly cancer, infection, and trauma. If you look at patients with a low ejection fraction, most of the deaths are due to sudden cardiac death and death from worsening heart failure, causes of death that we believe that we could modify with a treatment such as the mineralocorticoid receptor antagonist. If you look to the right of this figure, you can see that in patients with a normal ejection fraction or even a high normal ejection fraction, it's the minority of deaths that are due to those modifiable causes. So we've got a lower mortality rate, and amongst the deaths that do occur, a relatively small proportion of them are from causes that we can modify. And in this article, we did some power calculations and worked out that we would really need to do trials twice as big as Finearts to be able to show whether or not a treatment such as Finerenone or an SGLT2 inhibitor or any other treatment had an effect on mortality in patients with this type of heart failure. These are the other pre-specified secondary endpoints, so change in Kansas City Cardiomyopathy Questionnaire, NYHA class, and the renal composite outcome. In Kansas City Cardiomyopathy Questionnaire total symptom score, we saw a small but significant increase. That means improvement. Very small, but again, this is something that we've got used to in most of our large morbidity mortality trials. In fact, in both of the major heart failure phenotypes, whether it's heart failure with reduced ejection fraction or patients with mildly reduced and preserved ejection fraction, the actual effect, the average effect of treatment on this patient-reported outcome tends to be very small. There are two exceptions to this. One is intravenous iron therapy, and the other is GLP-1 receptor agonist treatment. And we could talk about that later if you want, but this is unfortunately the small effect that we see. Whether this means that these treatments really don't improve patient well-being very much, or whether it means that the instruments that we have to evaluate patient well-being are not very good, I'm not sure, although my own impression is that at least for SGLT2 inhibitors, they really do have a meaningful effect on patient well-being, even if we can't show much change on the Kansas City Cardiomyopathy Questionnaire. And then lastly, the renal composite endpoint showed really nothing. In fact, if anything, there was a trend for worse kidney outcomes in the Finerenone group compared to the placebo group, although as you can see here, the number of events was really small, 75 versus 55. And as I said, we had a lot of discussion about whether to actually include this endpoint. The sponsor was very keen. They believed because they'd seen this endpoint improve with Finerenone in trials in patients with type 2 diabetes and chronic kidney disease. We should see the same thing. Patients with heart failure, we told them that patients in heart failure actually don't accrue many hard renal endpoints, even over 3 years of follow-up, and that no other treatment really has a significant impact on those endpoints compared to what we see in patients with chronic kidney disease. And again, we published this paper to sort of try and explain this in a bit more detail. There are 3 sets of panels here, and therefore treatment with an angiotensin receptor blocker, SGLT2 inhibitor, and mineralocorticoid receptor antagonist. Here you see 2 bars for active and placebo treatment, patients with heart failure, compared to 2 bars in patients with chronic kidney disease for each of the treatments. And if we look at angiotensin receptor blockers here, you can see this striking reduction in kidney events with angiotensin receptor blocker therapy. This is from the Renal and IDNT trials from many, many years ago. But we see exactly the opposite in patients with heart failure. And really, this is also true for mineralocorticoid receptor antagonists. So I personally think that the kidney in patients with heart failure is probably different than the kidney in patients with type 2 diabetes, or it may be that these treatments really only work in people who are excreting a lot of albumin into the urine, because that is the other difference between patients with type 2 diabetes and chronic kidney disease in these other trials compared to the patients that we've enrolled in the heart failure trials. And then finally, just to show you a more conventional endpoint. So we did pre-specify sensitivity analysis looking at the type of endpoint that you're used to seeing in most clinical trials, a time to first event endpoint. So you can see here that the rate ratio and the hazard ratio were identical here. Interestingly, the 95% confidence intervals were a bit tighter around time to first event endpoint than around the total events endpoint. We, of course, did the usual subgroup analysis. We really didn't see very much variation by subgroup, but I will show you one subgroup in a moment that did show something I think that is interesting, but overall pretty consistent effect with no major modification of the effect of Finerenone by any baseline characteristic, with one exception that I'll come back to. The baseline characteristic that we had anticipated might modify the benefit of Finerenone was left ventricular ejection fraction. We were, I have to say, fully expecting to see attenuation of benefit in patients with a more normal ejection fraction. But in fact, as you can see here, and this paper has just been published very recently, the effect of Finerenone really was pretty consistent across the spectrum of ejection fraction. As I say, we didn't expect to see that. We, of course, are pleased to see that, but that was a little bit of a surprise. But the one subgroup I think that is interesting in terms of a treatment interaction is the subgroup looking at body mass index and patients living with obesity. And of course, that's a very, very hot topic in cardiovascular medicine in general, and heart failure with preserved ejection fraction in particular. And we had a lot of patients. We had about 2,700 patients living with obesity in the Finearts-hf trial. And these two panels at the bottom show you the primary composite endpoint and total worsening heart failure events, with that, again, same spline analysis looking at the continuous rate ratio and the 95% confidence interval around that. And of course, this is a rate ratio of 1 equating to unity, to no treatment effect. And you can see this unusually strong interaction p-value, so 0.054, again driven by an effect on worsening heart failure events, whereby the effect of Finerenone seems to be somewhat greater in more obese patients. Even with this very significant interaction p-value, I might have been tempted to dismiss this as a play of chance, except for two things. One is that we have data from patients with heart failure and reduced ejection fraction that aldosterone levels are higher in individuals living with obesity compared to those who are not living with obesity. And secondly, we saw a similar interaction like this, in the emphasis heart failure trial with the Finerenone in patients with heart failure and reduced ejection fraction, where we saw a significantly greater benefit in patients with a larger waist circumference. So there may be something in this interaction between MRAs and obesity. And out of interest, we had many, many more patients, many, many more events, and obviously longer follow-up than in the recent GLP-1 receptor agonist trials, which focused on patients with heart failure and preserved ejection fraction living with obesity. So these are the pre-specified safety and tolerability endpoints, and it will not surprise you that Finerenone caused more hyperkalemia, was of course associated with less hypokalemia, and very few cases of significant hyperkalemia and no significant increase in hyperkalemia leading to hospitalization. I think we're all haunted by that famous analysis from Ontario many years ago after the RALS trial showing an increase in hospitalization related to hyperkalemia in Ontario in patients treated with spironolactone. So nothing like that in this trial. So to put these results into some sort of context, I will show you the three most recent large trials that we've done in patients with this heart failure phenotype. You'll see here that the design of Paragon with sacubitril valsartan, Deliver with dapagliflozin, and Finerenone, which I've just shown you, really very similar. The NT-proBNP inclusion criteria also very similar, and therefore not surprisingly, the patient characteristics in the three trials pretty similar. One or two minor differences, because we did include a small proportion of patients in hospital or recently discharged from hospital in Finearts. The proportion of people with more advanced NYHA class was a little bit greater, larger in the Finearts trial, as was NT-proBNP level a little bit higher than, for example, in the Paragon heart failure trial, but otherwise really very similar patient populations. This is a very complicated table. I don't really want you to look at it, but what I've done here is I've put together the three trials. I've gone back to the original data sets and looked at exactly the same endpoints so that we can look at the same endpoints across the trials. I've put the number of endpoints, I've put the rate of the endpoints, and I've put the treatment effect size. And really probably the one to look at, and that I will expand on in the next slide, is the top line here, which is the conventional time to first event endpoint, cardiovascular death or worsening heart failure event. You can see here we didn't quite meet that endpoint in the Paragon heart failure trial. There was a borderline, but not definitively statistically significant benefit. Of course, we did see a significant benefit with dapagliflozin in the Deliver trial. And of course, I've just shown you the same thing in the Finearts-hf trial. And I said I would expand on that a little bit. And here I've shown you also the absolute treatment difference and the number needed to treat. And you can see that Deliver and Finearts are really very similar in terms of those two metrics. Now, it's not that I want to suggest that these two treatments are in competition. They're absolutely not. I believe that they're complementary and additive. And here is, I think, the unusually strong evidence that we have that that's the case, because it's rare that we're able to do this. But in the case of these two treatments, an SGLT2 inhibitor and a mineralocorticoid receptor antagonist, we can look at that interaction in both directions, because of course in our SGLT2 inhibitor trial, we had a lot of patients who were on an MRA at baseline. So we can look at the effect of an SGLT2 inhibitor in patients not taking an MRA at baseline and in patients taking an MRA at baseline, and the treatment effect was essentially identical. So it's really the point estimate here that matters and the interaction p-value. And if we look at Finearts, of course, we had some patients who were on an SGLT2 inhibitor at baseline, patients who were not, and again, you can see the treatment effect was identical. And in neither of these analyses was there a significant interaction. In other words, one treatment did not modify the effect of the other treatment. So I really do think the effect of these treatments, as I said, is complementary and their benefits are added. So to finish off with, I want to look at the million-dollar question, which, of course, is do all of the purported differences between these new non-steroidal MRAs and our conventional steroidal MRAs really matter clinically? And yes, these are very different molecules in terms of their chemistry, and they may have important differences in terms of their pharmacology and possibly in terms of their biological action. But do we know if they do anything different in terms of clinical outcomes? Well, the truthful answer here is I don't know, and nobody knows, because short of doing a head-to-head comparison in a randomized trial, we really cannot tell. You cannot tell by indirect comparisons. But of course, having just said that, that's exactly what I'm going to go on to do, with all the warnings that such a comparison, of course, should attract. And one of the things that we've known about spironolactone for a long time is that it causes worsening of glucose tolerance or glucose homeostasis. And there are several small studies. In fact, there are at least 3 meta-analyses of studies showing that spironolactone increases hemoglobin A1c. And the reason for that is really not clear. Some people suggest it's related to the fact that spironolactone can increase cortisol, possibly because it binds to receptors for cortisol and displaces cortisol. How exactly that leads to an increase in glycated hemoglobin, I'm not sure, but that is certainly the most popular explanation for this fairly consistent finding. And it was because we knew about this that we pre-specified that in the Finearts-hf trial, we would look at new onset diabetes as an exploratory endpoint. We did this more in the hope that we would show metabolic neutrality than anything else. But in fact, what we found was a really quite robust, consistent, significant reduction in new onset diabetes. In fact, there was about a 25% reduction in new onset diabetes. And again, we've just published this recently in Lancet Diabetes. So I think this is probably real, and I certainly think it's more than of trivial importance in patients with heart failure and preserved ejection fraction. And then the last thing I'll show you that is possibly different than with other mineralocorticoid receptor antagonists is the effect on liver biomarkers and bilirubin and alkaline phosphatase in particular. And we saw in Finearts-hf a significant reduction in bilirubin and in alkaline phosphatase. My own suspicion is that this reflects reduction in right-sided pressures, decongestion, although there may be other explanations. And as far as I can tell from looking at other databases and searching the literature, this has not been reported with conventional mineralocorticoid receptor antagonists. So to finish, I think that we've shown that Finerenone has a worthwhile clinical benefit in patients with heart failure and mildly reduced and preserved ejection fraction, that benefit driven primarily by reduction in worsening heart failure events and specifically worsening heart failure hospitalizations. These benefits were consistent across all of the subgroups that we looked at, and I think two particularly important subgroups are people with a relatively normal ejection fraction, and of course, as I mentioned, people on background SGLT2 inhibitor treatment, which of course should now be a standard of care in these patients. We saw more hyperkalemia, so you do have to be on the lookout for that, although I think hypokalemia is probably just as important. And I think the new guidelines hopefully will reflect these findings by recommending Finerenone in addition to SGLT2 inhibitors for treatment of patients with this type of heart failure. And hopefully, gradually, we're beginning to build those pillars of therapy that we're so familiar with in patients with heart failure and reduced ejection fraction for patients with heart failure and an ejection fraction above 40%. So thank you very much indeed for listening.
Thank you, John. As always, it was a great treat for us. We've of course seen the top line data. We've discussed it at rounds, but you always bring new data and updates, and we very much appreciate some of the new insights that you've shared with us. Particularly, quite interested to see the data on diabetes. I'm going to actually look at that paper. I haven't read that one in great detail, but and also your thoughts around that's something that is vexing for many in terms of the sort of different renal benefits in people with and without heart failure. So thank you for providing some clarity mechanistically, or at least some sort of hypotheses there. So Joel Ray has a question. Do you have an effect size figure of the hazard ratios by differing baseline BNP concentrations or different or by baseline blood pressure?
Yes. So in the paper, we've got both of those. So the median NT-proBNP was 1,041 picograms per mil. The rate ratio in people with NT-proBNP at or below the median value of 1,041 was 0.78. In patients with an NT-proBNP above the median value of 1,041 picograms per mil, the rate ratio was 0.83. And actually, interestingly, even within both of those subgroups, the upper 95% confidence interval didn't cross 1, although that doesn't really matter. Systolic blood pressure, we looked at people with a blood pressure at or below 130 millimeters of mercury versus above 130 millimeters of mercury, has a ratio of 0.85 and 0.84, again, identical.
Okay, thank you. Questions for Professor McMurray? I think we have...
God move here. Sorry. Hi, John. So first of all, I enjoy your talk immensely.
Thank you very much.
And also the focus issue that you also contribute to. I read every paper.
Oh.
So I have a question, a practical question is, I don't know about in the United Kingdom, but in Canada, a lot of patients with HEPAs already on spironolactone. So would you switch them to Finerenone? That's question number one.
I probably wouldn't, but of course, I suppose if I want to practice evidence-based medicine, I should. But I think I'd be happy if these patients are on any mineralocorticoid receptor antagonist. The United Kingdom's absolutely not like what you say is the case in Canada. And it's interesting because our experience in heart failure with reduced ejection fraction is that, surprisingly, like the United States, Canada is one of those countries with a relatively low rate of use of MRAs. And I always wondered if that was the hangover from the Durlink paper from Ontario in the New England Journal of Medicine, because Canada is usually different than the US, a bit more like Western Europe in terms of practice, but in HFrEF definitely is more like the US, and MRA use is relatively low. So I'm surprised to hear about MRA use being high in this type of heart failure in Canada, and it definitely isn't high in the UK, because I have to say people didn't really buy into the sort of subgroup analysis of TopCat very much over here. And again, our national guidelines don't recommend MRAs in those patients, and people tend to be very guideline driven here. So interesting differences between the two countries.
Okay. So what can I ask another question?
Yes, please.
Yeah,
thank
so
you.
in the past, when you talk about SGLT inhibitor, John, you said that you wouldn't even bother to measure eGFR initially, because invariably they would be reduced. So in the Finearts, they also reduced too. And would you not recommend measuring eGFR initially?
I think it's different. So we've actually published a paper on this again, maybe in that issue actually that you talked about, Gordon, where we looked at this, and it is slightly different with MRAs, and it's slightly different in maybe three ways. So with SGLT2 inhibitors, a dip in EGFR is almost like a predictor of people are going to do better. People are going to have greater cardiovascular benefit, and also be less likely in the long term to show worsening kidney function. No associated risk related to the decline in EGFR. So, for example, no excess risk of hyperkalemia. It's not quite the same with MRAs. The pattern is a little bit similar, but not the same. So, yes, if your eGFR falls with an MRA, with Finerenone and Finearts, it's not as bad if your eGFR falls on placebo, but it's still associated with a higher event rate. And I think the important thing is it's associated with hyperkalemia. So I think that's why you need to check you've got to check potassium and kidney function in these patients. So I wish I could give the same sort of reassurance that I think most of us would agree with for SGLT2 inhibitors for MRAs, but I don't think you can.
Thank you.
Thank you. There's a question. Thank you, Gordon. There's a question from Dr. Paul Dorian. You mentioned a surprising number of patients on beta blockers. Should we be doing more to discourage this unnecessary therapy?
I'd be interested to know what Paul thinks. I have to say, I have personally, when I see my patients now, I really do think about why they're on a beta blocker and whether they need to be on a beta blocker and the dose of beta blocker that they're taking, because you've seen the withdrawal studies showing improvement in functional capacity, improvement in symptoms in people who've got at least chronotropic incompetence associated with beta blocker use. And I think that's maybe more common than we've realized. And okay, maybe we do have to use beta blockers, for example, in people with atrial fibrillation to control their ventricular rates. But I think we also can think about the dose of beta blocker we use and how well controlled their ventricular rate has to be. So I certainly personally would love to see more studies, bigger studies, looking at beta blocker withdrawal. I don't think it's going to be possible to do a beta blocker initiation in these patients because so many of them, I mean, it would be almost impossible to recruit enough patients to study beta blocker initiation compared to placebo in these patients, but we could do a big beta blocker withdrawal trial, and I think that might not be a bad thing. But I don't know what everybody else thinks. I see Paul's on.
Paul?
What do you think?
Well, thank you for that answer. Of course, I completely agree with you. I think my hunch is that this is just a symptom of the concept that people don't really distinguish in a way they might between heart failure with reduced and with preserved ejection fraction. There's a bit of a reflex, heart failure equals beta blockers, just like people say now, coronary disease equals beta blockers, or age over 35 equals beta blockers. I just think it's sort of a symptom of recipe-based medicine, which I'm not a big fan of.
Yeah, I think that's a good point. I mean, I was charitably attributing it to coronary artery disease, atrial fibrillation, maybe hypertension, even though beta blockers, well, at least until recently, were out of fashion as a treatment for hypertension. But yeah, you're probably right there.
If I may, I just want to say thank you very much for visiting with us in Canada.
Oh, thank you very much.
No, it's very much appreciated. Yeah, John, I was going to ask you a question about the sort of the obesity analyses, and also, it's as you mentioned, it's such an exciting time and for people living with overweight or obesity, for which there've been limited sort of solutions. But in all of the SGLT2 inhibitor trials, the efficacy has been consistent, but there hasn't been the signal of a widened benefit like you've just shown us in people with overweight or obesity. And I'm very intrigued by that mechanistically. And you alluded to, the sort of data that maybe this is a group that has higher RAS activation, higher aldosterone levels. Is that being measured, or can that connection be made in terms of baseline aldosterone?
So Subodh, the only trial I have access to where we've got aldosterone measurements is the Atmosphere trial. We never published this because nobody's interested in the Atmosphere trial, but I have gone back and we've looked at people aldo levels according to BMI, and as has been suggested sort of in the literature from some very small mechanistic studies, from animal studies, from cell studies, actually people who have got higher BMIs do have significantly higher aldosterone levels. So there seems to be something in it. I mean, there are a lot of strands of evidence that together suggest that there may be something going on there. And then, as I said, in the Emphasis heart failure trial, which was our HFrEF trial with the Finerenone, we actually found in that study, we didn't actually look at BMI. We thought waist circumference was a better measure of central adiposity. And unusually, because in most heart failure trials, we don't have waist circumference, we did have it in Emphasis heart failure. And again, exactly the same sort of interaction was shown there. We went back, we looked at RALs. We don't have anything in RALs except weight, so we can't even calculate BMI in RALs. But interestingly, there is a significant interaction with weight in the RALs trial, which of course was the original spironolactone in HFrEF trial. So there are all of these tantalizing bits of evidence that all do seem to tell us the same thing.
What are your thoughts on the obesity field as it relates to GLP and the single G to double G to triple G to quadruple G to 5G,
So I have lots of thoughts about it. So first of all, I thought the Summit and the STEP-HFpEF trials are amazing for the size of the benefit in the patient-reported outcomes and in functional capacity. I mean, these are unprecedented. We really just don't see treatments do that. Now, I suppose the question is is that a benefit related to simply losing weight, or is it something to do with heart failure itself, heart failure per se? You obviously can't tease that out from the trials that have been done. And of course, there are many, many questions that we have. So you and I know from doing older GLP-1 receptor agonist trials in patients with type 2 diabetes, that you see benefits in people who are not obese. You see benefits at doses of these agents that don't reduce weight. So, for example, the albiglutide trial that I led, we saw significant reduction in CV death, MI, and stroke with a dose of albiglutide that did not reduce weight in patients with type 2 diabetes and cardiovascular disease or very high cardiovascular risk. So these drugs work independently of reducing weight. We know that, to reduce cardiovascular events. So teasing out all of those things, I think, is what's crucial here. And it's really crucial for the rest of the world because, as you know very well, if you go to Japan or to Korea or to China, people are not interested in these
Weight loss,
trials in people with BMIs of 30 and above. They don't see people like that. But of course, they've got lots of people who've got heart failure and preserved ejection fraction. So we have to understand whether these drugs have got a broader indication in patients with heart failure and preserved ejection fraction beyond obesity. And then, of course, there's the extremely thorny question of patients with heart failure and reduced ejection fraction, and the fact that these drugs, as you know, increase heart rates, which we would, I think, generally regard as undesirable in patients with heart failure and reduced ejection fraction. And of course, the agents that are also glucagon agonists. I mean, glucagon is our old treatment for a beta blocker overdose. You inject glucagon to increase cyclic GMP post beta receptor, and increasing cyclic GMP in the cardiomyocyte is not a very good thing to do. So again, I do think there probably are safety questions that need to be answered in patients with heart failure and reduced ejection fraction. I don't want to exaggerate it, but I do think it is a question, and how exactly we tackle that, I don't know. So I think there are probably, many questions that still have to be answered. I'm delighted to hear that there's one, probably two already large outcome trials getting underway with some of these new agents. So it'll be great to see whether or not we can get that third pillar of therapy, Subodh, for your famous figure, this time for heart failure with preserved ejection fraction.
Yeah. Thank you so much. I just, as you were talking about the trial on albiglutide that you led, I saw that Larry was on the line as well, and I remember you and Larry and the team presenting that late breaker at the ADA meeting several years ago in a packed audience where you showed a 20% or 25% relative risk reduction with modest changes in weight. And I think that helped.
Only for the drug to be discontinued. Yeah. If Larry's on, it would be really great to hear what he thinks about GLP-1.
Larry, are you on? Hi, Larry.
Hi, hi, everyone.
Larry, long time no
hi,
see.
John. How are you doing?
Brilliant to see you. So, Larry, what do you think about the weight versus weight independent effects?
I mean, I think there's both. I certainly think the weight loss plays an important role, but there's all kinds of lines of evidence from the studies you've mentioned that even people who don't lose a lot of weight or who lose no weight, as with the case in Harmony Outcomes with albiglutide, still show benefit. So I think it's an all of the above answer.
And Rory Holman published a paper in the European Heart Journal in the past few months with Milton Packer from the Excel trial, suggesting that in patients with reduced ejection fraction, the hazard ratio is above 1 in people getting active therapy. Now, again, it's sort of retrospective and subgroup, but again, it was interesting in pointing to that possible safety concern. So it'll be interesting to see whether anybody has the courage to go into heart failure with reduced ejection fraction with one of these agents.
We've tried having that discussion, John, and I'm sure you have too, and it's met with a lot of caution, and I haven't heard of any successes there. But one thing that I know we're out of time, but one thing that I wonder, both for you and Larry and other friends on the line, is whether mechanistically overweight and obesity's role pathophysiologically in ASCVD could be different in people with HFpEF. What I mean is that it is possible that there may be there are weight-independent effects on the sort of ASCVD sort of natural progression. But the literature on the link of overweight and obesity as a risk marker for HFpEF, suggests that the greater your BMI, the greater the weight, the greater is the actual incremental risk of heart failure hospitalization, suggesting that maybe that obesity may have a different kind of relationship with HFpEF than vascular disease.
It's a good point. I mean, Larry probably knows more about this than I do, but actually a long time ago, I studied, I published a paper. We have a very, very large epidemiological study from this part of the world where an astonishing proportion of the population of a local city took part in this trial, and we've been able to follow them up through Scottish record linkage for a long time. And sort of 30 years after they were screened, of course, many people had a cardiovascular event. But you're absolutely right, Subodh. By far, the greatest risk associated with obesity in that epidemiological study that we reported was heart failure, much more strongly associated with obesity than stroke, myocardial infarction, or even atrial fibrillation, which actually was also quite strongly associated with obesity. So I'm sure there are other data from other places. I don't know if they're consistent with that, but that's certainly what we found.
Well, thank you so much. I think we're out of time. John, thank you so much. This was wonderful. We're honored that you've spent an hour with us. Thank you very, very much, and we look forward to seeing you in person.
All the best. Bye-bye.
Okay, Tina, thank you so much for the great round. I never thought the ECG reading is as complicated. Luckily, I only look at ST segments. So, we'll open this the floor for questions. So actually, just wanted.
Tina, maybe.
Yeah, Sean, go ahead. No, please do.
Sorry, Tina, great job. Very complex area, very exciting. I'm definitely not an expert on calibration and discrimination and C statistics, but I did recall that, for example, the very impressive Noseworthy, the Mayo Clinic analysis that was published in The Lancet that you talked about as an example of the potential for AI to sort of predict the C statistic, the sort of calibration was fairly modest, right? I mean, in the 0.6, 0.7 range. Now, that's not to be critical because, the gray score that we developed for clinical predictors, clinical factors in a post-acute coronary syndrome patient population to try to predict what their outcome might be in the next, year's time is, not a whole lot better than that. The CHADS VAS scores that we used for predicting, again, the likelihood that somebody with atrial fibrillation might have a systemic embolism, embolic ischemic stroke, again, are not, the calibration is not a whole lot better. But it is a reminder that even with AI, those C statistics, those calibration, that ability is modest at best. And so I'd just be interested in your thoughts on AI as a potential great tool, but whether, does this offer up that much more than sort of conventional statistical analysis and developing a score, which of course is much less black box, as you pointed out, than at least for most of us from AI. So are we that much further ahead at this stage in time compared to a traditional multivariable logistic regression or other statistical tool methods to land on something that's sort of clinically applicable?
No, it's yes. The papers didn't really talk too much about calibration, and there are some papers where they looked at the AI risk score as an addition to something that's clinical. So in addition to the Charge-AF score, as an addition to the Toronto or the Mayo score. And I do recall that I think in some cases it may be marginally better. Some cases actually there was no difference. And I think where it becomes helpful is where we didn't have risk score. So for example, the asymptomatic dysfunction, we currently don't have risk score for these patients. So short answer is I don't know. And I think that we may need a little bit of modeling to see how effective it can be and how cost effective it can be, as someone mentioned, the overall in the healthcare system. And the second is I think we need real world data to actually see.
Yeah, but very exciting. And thank you for sharing that.
Excellent. Any other questions? I mean, Tina, I just have, so you mentioned EPIC as a one way of looking at it, but let's say, in a family practice where this can be utilized, I mean, I don't have experience with AI, but I understand there's a lot of AI softwares and developers, not necessarily ChatGPT. So how do you foresee this? Is it like a picture of an ECG you upload to an app, and are all the AI, obviously created equally, or is it going to be, a source of confusion of if you get an AI result, is it from this provider or this, or is from this software or the other? How do you foresee this in, let's say, family practice? Because that's where a lot of screening for cardiac conditions may take place.
Yeah, I think before we implement it widely, there definitely is a same point as made prior. We definitely need to actually see some real world data. In terms of the software, right now it's not proprietary. It's in the public domain. It's not easily accessible. I don't know if family practice is the right place to implement it, is what I would say. And if the AI research does continue to evolve, and on the flip side, it may become a screening guideline. So for example, all patients above a certain age with smoking history should get an ultrasound for diagnosing AAA. And would AI algorithm be similar in weight and in effectiveness as those type of screening tests? I don't quite think so, because it's still an intermediary. It's not like ultrasound actually give you a diagnosis of AAA. Well, ECG will only give you a probability. So I guess the conclusion, one, I don't think family medicine will be adopting it anytime soon. And two, the algorithm will probably stay public. I don't think this is going to be a proprietary algorithm. And ultimately, it will be like the various type of risk scores that we have for diagnosing heart failure outcomes. There's a Seattle, there's a bunch of others. It will be up to the clinician to decide which to use. But I think for now, and the idea of the AI algorithm is that if someone else were to develop an algorithm, it shouldn't be that far off, is the idea. So even if there are multiple algorithms, I don't think it will make a huge difference.
It's interesting in the CCS guidelines. It's interesting that there's an element. Oh, sorry. There's a recommendation on opportunistic screening for AFib, for example. Not necessarily ECG based, but clinical examination, or so it will be interesting to see when this is more mature, how would that apply? Okay. I'm mindful of the time. Any time for any last question? And I have to ask if this was applied in STEMI. I cannot not ask. So is there any research in that area?
I don't think so. Okay, and no. And I think the idea is for it to be a screening test, not a diagnostic test, right? The ECG STEMI is more of a diagnostic test. And I don't, if there's a clinical suspicion is strong enough, I don't really care what AI tells me on the ECG, the patient's getting a cath.
Okay. That's an important message. Okay, excellent. Well, Tina, thank you so much for the great round, and thanks everyone for being here. And just a reminder to fill the evaluation for these rounds. And again, thanks everyone.
Thank you all.
Well done. Thanks so much, Tina.
Great job, Tina.
Thanks.